Okay, so very warm welcome everyone to what is the 22nd talk in the Medical Humanities Colloquy. We've been doing this seminar series more or less from the time of COVID. So there's an interesting contextual intersection of medicine and social realities that we all had with the pandemic. And it's during the pandemic that we started this seminar series, and we've had a number of talks on various humanities areas, from medical sociology to medical history and literature and theater, narrative medicine, various sorts of approaches to this very broad church of medical humanities, which is more like an umbrella term for talking about all kinds of, let's say, humanities approaches to medicine as a cultural practice, and not, of course, in terms of scientific technicality, though sometimes there is a very interesting engagement with that scientific technicality that we get in medical humanities approaches too. And I'm very happy to have Dr. Apalak Dash today. Let me introduce Dr. Dash before we get into his talk, and he will be talking about his recently published monograph. The title of his talk is Empire and Leprosy in Colonial Bengal. And Dr. Apalak Dash is assistant professor in the Department of History, Rani Birla Girls College under Calcutta University, India. He did his PhD from the Department of History, Jadavpur University, on leprosy in Bengal in 2022. And I'm assuming this monograph is a product of his doctoral research. In some sense, his research looks broadly at the social history of medicine in colonial India. He was also a former research fellow of the History of Medicine Fellowship at the Asiatic Society, Kolkata, for a 2-year term, 2017 to 2019. I'm very happy to have you, Dr. Dash, and it's over to you now. Thank you so much. Yeah.
Thank you, Orkoda. Am I audible? Okay. So greetings and good evening to everyone. I would like to thank Medical Humanities Colloquy and Orkoda Muthumitadi for inviting me to deliver a talk on my recently published monograph, that is Empire and Leprosy in Colonial Bengal. And as Orkoda has just said that, yes, it's a product of my doctoral thesis. And I would also like to thank this gives me an opportunity to extend my gratitude to my supervisor, Professor Mohua Sarkar. Without her relentless nagging and perseverance, this book could not have been possible. Okay, because she kept telling me that when you are going to publish your thesis, okay, after my death, so you should come with your book at my funeral, and then it will be the homage. And I couldn't take it anymore. So it's a persistent nagging that led me to publish this one. Frankly speaking, I have had no such idea to publish this thesis so early. So I said that, okay, ma'am, just I have finished my thesis. Let me give some time. I will settle down. I will try to revise and say that. She said that no, it's done. What you have done, it's totally a format is ready. So now you are up to your neck. So you have to publish it early. And once you are going into the work, you will get entangled with so many official paraphernalia. So it will be late. So it's better to publish now. So that led me to get into this venture. Okay, and it took me 1.5 years, and I approached Routledge first, and simultaneously I have approached other publishers as well. But Routledge gave me a proposal that okay, this sounds interesting. This theme is interesting. So why don't you give me in a format? Okay, give your title, give your keywords, abstract, chapter divisions, and your CV and all that. So, and that actually happened, just was like that. So I was very happy that yes, my book is going to be published by such a renowned publisher. And also, I would like to thank, in this regard, my other professors, such as Professor Suchetana Chattopadhyay, uh, Professor Kaushik Roy, Nupur Dasgupta, Professor Nupur Dasgupta, Devjit Dotto, Shekhar Bandyopadhyay, Poonam Bala, Professor Poonam Bala, and Jane Buckingham, who gave me support and also who actually gave endorsements in this book. If you go through the uh, uh, first few pages, you will find that they gave me endorsements. I have approached them for endorsement and they gave me generously. And also, I would like to thank that person. Uh, Without his guidance and without his support, this I could not publish this book. His name is Deepak Kumar, Professor Deepak. Deepak Kumar, I don't know what he found in me. He was so, down to earth, so encouraging. So always he encourages the young scholars to publish the thesis, to go to the archive. Okay, and he also very much, he's fond of archival research, empirical research. He said that Apalak, तुम्हारे पास जो है वो काफी है. Now you should publish your book. After when I got his forward for my book, and he was so happy, said that Apollo, I kept telling my other PhD candidates, my students, they didn't publish their thesis so early. So you listen to me, and thank you for that. And that is something else, because I approached him for some papers that I want to go through. I couldn't find those papers, Leonard Rogers papers, Manson papers that are very valuable for my research. And when I asked him for that papers, he just gave me. He mailed me everything, whatever he got, the primary archival data, primary correspondences. That's are very valuable. That these papers are very valuable for me, for my PhD research. And he gave me entire collection that he has. Now, the thing is, first of all, I would like to share my experiences, the making of this book. Then I would share my experiences, my toil that I have gone through during my research. And I will then say a few words in brief regarding my book. Okay, now this book is broadly divided into 4 chapters. I will explain all these chapters very briefly. Okay. Now let me tell you one story that it's all started when I was in MPhil student. Okay, when I was MPhil student, and in 2016, I was totally dissatisfied with my MPhil dissertation. I was about to submit my MPhil dissertation. That was totally on a different theme. It was on courtyards in colonial Calcutta. Now, the topic was very interesting, courtyards in colonial Calcutta. And I wanted to show that how the spatial configuration shaped the mentality of the Calcuttans, of the residents of colonial Calcutta, and how the colonial state approached and shaped the idea of space. Okay. Now, while I was going into the research, going into the detail, I have found that there are little evidence on the courtyards of middle class family. What we have got mainly the courtyards of babus, rajbaris, okay, palatial mansions, the courtyards of palatial mansions and all that. But there was a little evidence, archival evidence, which is very important for an empirical research on middle class courtiers. So I had traveled along North Calcutta, and I have found some, that was my survey, that was my field survey, and I have gone through all the middle class families, courtyards and all that, but that didn't materialize my argument. There was a problem in materializing my argument, my hypothesis, and I was confined to those palatial mansions, courtyards, and there are little depiction, only the depiction that we have in literature, contemporary literature. I have to go to articles written by Bankim, Rabindranath, memoirs, Bengali memoirs, and the memoirs of Sahibs, Maims, okay, travelogues of the Europeans, contemporary Europeans who visited colonial Calcutta during 1830s, 1840s. So that's all. Uh, there are little evidence on that. Only the building commission that was formed in 1897. Since 1880s, the sanitary commissioner's report I have got, and I got some evidences of courtyard. Okay, they were very serious. They were concerned about the inner space and outer space. Okay, they are very concerned about the shape of the courtyards. Okay, so it was since 1880s. So my period, my research starts from 1801, since Wellesley's Minute, uh, when this the urban planning germinated. Okay, now I was totally dissatisfied with my work, and while I was doing this research, I had come across a few details regarding public health. That is in West Bengal State Archives and National Archives. I've gone through some reports, and I found that's an interesting area to be explored. So that kept haunting me, that you should change your arena, because this is something that you need more theoretical orientation, and theoretical orientation and some architectural ideas, perhaps ideas about space. And I am not good at theorizing a particular genre. Okay, so I just shifted to my empirical research. So I told my supervisor, uh, Mohua ma'am, that something is wrong, ma'am. I'm not satisfied with this work, dissertation. So I wanted to change my arena. I wanted to change my field. So she said that, then what will you research in PhD? Won't you continue this particular field? The courtyard is a good thing. So she said, I'm very much, in a dilemma. Whether I was in a dilemma, I didn't know whether I should continue this or not. Now my what should I say? My brother, my mentor, Shubhankar Da. Shubhankar Da said, Shubhankar De, assistant professor in Shidukanu Birla University. He was then in PhD. He was working on tuberculosis. And when I approached him, and when I expressed my dissatisfaction about my MPhil thesis and said, "Oh, Shubhankar Da, it's not going well. What should I do?" And so he said that, why don't you join medical history? You should work on some disease or public health. You have got some report as well. You have gone through. So that's an interesting area. Frankly speaking, prior to that, I didn't have any idea about medical history or history, science, technology, or medicine. It's an arena that I only heard that it's a good emerging area, aspiring area, that everyone is engaged in these areas, exploring various aspects of medical history, medical humanities. But I didn't have any orientation at that time, and I have no idea. I didn't have any idea. So I said that, Shubhankar, I didn't have any orientation. Well, there is no point of orientation. You have had, already you have done extensive research on space, na? So you have gone through public health reports. So that's it. You should get into it. There's a one point that he didn't tell me that time. Now he always has been telling me that there was a interest. I have had a kind of interest because I wanted you to be involved in this field. So we will work together. And that time I didn't select my research theme, that is leprosy. That was another interesting story. When I have finally decided that yes, I'm now going into a different field. I want to explore medical humanities, medical history. So I had to select one topic. And that time I have read Somoresh Bosu's or Calcutta's Shambhu. It was there in my library in my home, and I didn't read it before. So now I took that book and I have read it. So that's very amazing. Means the storytelling, the way in which Calcut explained, depicted a mythological character in a very what should I say? It's a very uh, complicated and very natural way. It's very fascinating. The story, very fascinating. So after that, um, I am I audible? Okay. After that, I have watched a film that is Ek Doctor Ki Maut, directed by Tapan Sinha. No, these two, one novel and one movie, changed my course, means changed my way of thinking. Because in Dr. Ki Maut, the person who was, researching on perhaps IVF, his main research was on leprosy. Okay. So these two incidents, reading a novel and watching a movie, these two incidents led me to, in this field, leprosy. And I have come across that extensive research has been done on leprosy. There are works of Vishwamoy Poti, Jane Buckingham, uh, Stephen Snelders, Rod Edmund, multiple scholars. They have quite they have explained, they have researched extensively, but none of them has taken Bengal into account as a research area. Jane Buckingham has explored South India. Vishwamoy Poti has explored colonial Odisha. Okay, Rod Edmond explored the entire British Empire. Stephen Slendal, Dutch Suriname. So everyone has different perspectives. Joe Robertson has explored, explored the leper asylums in British India into account. But none of them, and there has been a kind of a little light on particular area, that is Bengal, colonial Bengal. So I have selected leprosy in colonial Bengal because I found nearly nothing is there in leprosy in colonial Bengal. So that is the beginning. And when I expressed my theme, when I explained this to my supervisors and said that, ma'am, this leprosy, as a good theme to be researched, to be explored. So ma'am said that it's a good one because there is no work on leprosy in colonial Bengal. So you should work on this. This would be a good thesis. So I have started since 2017. Before that, in 2016, I got the fellowship in the Asiatic Society, History of Medicine Fellowship, right? So that is That is in 2016. And already I have started working on that, working on leprosy. Now, no, now I would like to share something about my research experience. Now, doing research in India is a kind of, Sisyphean task. That is something, we are far behind from our Western, from our Western European friends. Because in India, you have so many paraphernalia, you have so many impediments. As a researcher, I feel that we have to go through all these impediments before getting into the main documents or any letters, correspondences. The governmental paraphernalia are so so discouraging that every researcher always finds difficulty to continue or pursue or carry out their research. Every researcher, and that is something I have found. I am just giving you one example. For my research, I had to go through some documents, letters of Leonard Rogers, right? Leonard Rogers, for those who don't know, Leonard Rogers, one of the founding members of Calcutta School of Tropical Medicine. Calcutta School of Tropical Medicine was the brainchild of Leonard Rogers. And Leonard Rogers was enthusiast, medical enthusiast, protagonist, and he researched on several arena, since in the late 19th century till 1920s. He researched on multiple aspects, of medicine or public health. He researched on cholera, researched on leprosy, researched on malaria, Kala-Azar, and the ambit of his research was so problematic that his friend and colleague Sir Patrick Manson, who got Nobel Prize in I think in 1905. Now, Patrick Manson said one of his letters to Leonard Rogers that you should confine your research, you should restrict your research to a particular field. Don't go around here and there and research on everything. It will be, it will be difficult for you to comprise all these data. So you have to restrict yourself. So that was very interesting, and in a very humorous way, Patrick Manson explained the problems of tropical diseases research, the dynamism of tropical disease research. So Leonard Rogers and some documents related to Leonard Rogers, the private correspondence, some books, even since 1920s onwards, the journals published by Calcutta School of Tropical Medicine, annual reports of Calcutta School of Tropical Medicine, these are all documents preserved in the library of CSTM, Calcutta School of Tropical Medicine, right? So I had to go through all those documents. I wish to go through all those documents. And I approached the librarian of Calcutta School of Tropical Medicine. I don't take her name, but I'm sorry to say that when I approached her, she said that first of all, you need to tell me that what kind of documents you are going to research. What kind of documents you want. I said that unless and until I have gone through the catalog of this library, how can I tell you that which documents are important for me? So she said, no, you have to tell me first that what kind of documents you need. Then I will approve you. And she said, and in a day, I remember that I had to travel Jadavpur University to Calcutta School of Tropical Medicine 4 times in a day to get my supervisor signature in a particular paper 4 times. Every time I went to Calcutta School of Tropical Medicine, she said that no, this sign should be here, not here. Then again I had to go to Jadavpur University, took the sign of my supervisor. Then I came back to Calcutta School of Tropical Medicine and again said, no, you had to paste the picture. I understood your urgency, but this is the only way. This is the procedure that we all had to follow. So
Sorry, Dr. Das. I mean, I know this is in a way. I mean, you're narrating your research experience, and there's a lot of interesting humor, some of it being black humor too. But I'm just, because I'm aware of time, I'm just telling you, maybe if you want to talk about the book a little bit more,
okay,
it might be useful for those who are working in medical history,
okay.
like the kind of arguments you make in the book, right? I mean,
Okay.
because now that we've spent some time on the research experience, maybe I was wondering, I mean, if you don't mind.
No, it's
Yeah,
absolutely,
yeah.
absolutely. No, okay. So I'm just, I just shift to my book. It's broadly divided into 4 chapters. Okay. And the central theme that this book revolves around is objectification. The dynamism of objectification means how the leprosy sufferers or diseased bodies were objectified by the state, the society, the medical institute, and the missionaries. So basically how these 4 institutions during colonial period, during British period, how these 4 institutions had seen, observed, perceived leprosy sufferers. So that is the central thing, objectification. Now the thing is, it starts with, I have started my argument with Shambho stories, that how Shambho cured his leprosy and how he got cursed by his father. And then I started that there are multiple depictions, various references in Bible, in religious texts, various religious texts, in Smriti texts, in Puranas. So I don't go into those details. I have just referred to that how many times these Puranas, uh, with reference to leprosy and the instances of leprosy sufferers in Bible, in medieval Europe, how many times these references were made in 19th century. Okay, whenever there was a question of leprosy was, today leprosy, uh, uh, it is a kind of contagious disease that we all know, and leprosy still prevails across the world, especially India and Brazil. Now the thing is, initially, leprosy, British government was not concerned about leprosy. British government was concerned about the epidemic diseases that actually wrecked the economic system, public health system, okay, and that actually wrecked the entire socio-economic system, that 19th century socio-economic system that wrecked the system, that devastated the system. So they were much more concerned about combating the epidemic diseases. Lots of reports were made, but only British government came to know about this vicious disease and its impact now after the death of Father Damien, a Belgian priest who worked in Kalua Papa and Philippines. Okay. And he died of leprosy in 1889. And that time, the British government formed the National Leprosy Fund and Leprosy Commission in 1890-1891. Leprosy Commission visited India and submitted its report in 1893. Now, prior to that, only one report available, that was in 1867, that a report of called Royal College of Physicians. Royal College of Physicians, they prepared a questionnaire in 1864. And that questionnaire was sent to British India, and further it was sent to the local government, local governance, and asked them to prepare a brief report about the condition of leprosy in their respective provinces. Now, while the Royal College of Physicians got all the reports from British India, they prepared the report and published it in 1867. And they said that leprosy was a hereditary disease. Okay, there was a question of heredity, though a number of provinces were there who, the stakeholders, they didn't know about the contagiousness. And they didn't disclose, but they didn't have any information that how far it spread. Okay, how many leprosy sufferers existed in their area. Okay, so there were some gaps, but apart from that, despite those gaps, Royal College of Physicians, they published the report and said that it seemed that leprosy was a kind of hereditary disease. But in Leprosy Commission's report in 1893, is much later. Now, why there was a shift, I'm telling you that since 1870s, there was a shift in medical academia, a shift in seeing the diseases, because the germ theory appeared. Germ theory gradually replaced the miasmatic theory that prevailed since 1830s, 1840s, and it existed till 1880s. But surely from 1870s onwards, a number of experiments happened. Robert Koch, Patrick Manson, our Ronald Ross, they came to the stage, and they found some bacillus, okay, bacteria, virus that played, those agents, causative agents, played a pivotal role in spreading diseases. Not the miasmatic theory or area or putrefied area was responsible, no longer was responsible for the disease. Now, this actually changed the mentality, and it reflected in the report in 1893. Now, the colonial approach that prior to 1889 was totally different. And after 1889, when there was a death of a Belgian priest, and not only that, this particular incident triggered the concern, but late 1870s and early 1880s, some of the intelligentsia, Bengali intelligentsia, and as well as our Bhadraloks, Parsis of Bombay presidency, they pressed for a kind of stringent policy against leper beggars, quote unquote. Now, the leper is very discriminating term. I'm using this because it's mentioned everywhere in the colonial report, so we can use it within quote. Now, these leper beggars became problematic, turned into a problematic one in various cities, so Bombay, Calcutta. The local intelligentsia, Bhadraloks and Parsis, they pressed for stringent colonial policy. And always they were, supporting the segregation, the policy of segregation, that colonial government should implement segregation policy in this regard to prevent the contagion, to prevent them loitering in a public domain. Okay. Now, this thing continued till 1880s, and when this report came in 1893, Leprosy Commission, the commissioners, the members of the Leprosy Commission, they, but it is not as disease. It's a contagious, but it is not as contagious as them. Once, okay. Now the thing is, it was not as the members of the Leprosy Commission, they were of the opinion that it was not as contagious as smallpox, cholera, or other epidemic diseases, plague. So there was no question of All India Confinement Act or All India Leper Act. It was clearly stated. But the problem is the British India was so scared of this disease because the manifestation, the manifestation, the bodily manifestation, the way in which it actually came out, over the faces, hands, and the way in which it deteriorated, because there was no cure that time. Only the chaul mugra oil and gurjan oil, these were two medicines that were frequently used over the leprosy sufferers. Unless, except those two medicines, there were hardly any curative medicine. There was no preventive medicine. Only the curative medicine that we are talking about. Yes, nowadays there is a question of leprosy vaccine, but it's mainly the curative disease, the MDT, multi-drug therapy, that came in 1980s, and still it's used. This MDT is a curative drug, not preventive drug. So in epidemic diseases, largely we have preventive medicine, vaccines. In leprosy, there is no question of prevention. Only when you contract the disease, you will have to take the curative medicine, that is MDT. Now, that time there was no concept of MDT, only cholmogra oil, and that oil was administered orally. There was no intramuscular or intravenous administration of this oil. So you have to take orally, or you have to knead the entire body. Kneading that oil over the body, that is the only procedure of to cure from leprosy. Now the thing is, it was so British government was so anxious, and at that time in 1890, I think 1898, there was a leprosy conference, Bergen Leprosy Conference. It took place at Bergen in Norway, and in that conference, all of them, the members, the representatives of all over empire and all over world, they agreed upon one point, that is the confinement of leprosy sufferers is required. It's a necessity, because that is the only way you could prevent. You can prevent the disease. You can lessen the disease. The danger that we are experiencing now, soon it will spread all over Europe. Now, let me tell you something, that Europe also had gone through such phases. At times, medieval Europe, leprosy was prevalent in Europe. In 11th century, if you go through Michel Foucault's Madness and Civilization and History of Insanity in the Middle Ages, you will find that leprosy was to some extent prevalent in France and in Germany. That time it was not Germany, but provinces of North Europe and Northern Europe, England. And now, since 16th and 17th century, it got disappeared. And then these leprosaria or leper asylums that existed in medieval Europe, they were transformed into lunatic asylum. They were turned into lunatic asylums. The argument that Michel Foucault has presented, that there is no point of any kind of cure. Only the government and the state wants the diseased bodies to be confined, to be controlled, to be regulated. So the leprosy sufferers, when leprosy got disappeared, mentally unstable people, they took place of leprosy sufferers. The structure remained. And that is something exclusive to us as well. Now, I have found a particular leper asylum that actually turned into a turned into a hospital of mentally unstable people. That is our Calcutta Leper Asylum, or Albert Victor Leper Asylum. Nowadays, it's called Pavlov Institute. The same building, the same structure. Now, the Calcutta Leper Asylum started its journey from Beleghata in 1811. And I have mentioned it exclusively, extensively in my second chapter, that how the leper asylums, they appeared, they were established, and lots of leper asylums controlled by missionaries as well. Now, coming back to our point that at Bergen, when this confinement policy was stressed, then the British government in India published an act, implemented an act, that is All India Lepers Act in 1898, and it spread. It implemented all over across India, by and large 1901, 1903. In 1911, 1913, it spread all over India. It was implemented all over India. So that the suggestion that was made by the Leprosy Commission in 1893, that was not listened. That recommendation was totally rejected, and going against the decisions or suggestions of Leprosy Commission, British India government stressed upon, emphasized All India Leper Act. And this is how the mentality or approach, colonial approach, changed towards leprosy sufferers. Now they were supporting, they started supporting leprosy establishment, leprosy confinements. There were a number of missionary organizations. They played pivotal role in establishing leper asylums. One of them was Mission to Lepers. Now, Mission to Lepers came into existence in 1874, and by 1880s and 1890s, they almost established leper asylums in each provinces. Means in Bombay, in Calcutta, in Purulia, okay, Bengal Presidency in Purulia, Raniganj, lots of leper asylums appeared, mushroomed, and most of these leper asylums were under the control of Mission to Lepers, missionaries. And this is a good chance to proselytize them, because they were rejected and dejected by the families. There was no way to go. So they found this place, this seclusion, as their own world. These places or spaces, you can call it, it's a kind of a world within a world, a space within a space, where they could build their own palace, they could live their own lives. Only the Jesus, only the God is there to protect them. That was something that told by, proselytized by, directed by the missionaries. And I have gone through several reports, annual reports of Mission to Lepers, where the superintendents of these leper asylums, they spoke for these leper inmates. They said that, okay, the leper inmates were very happy about the way in which the way in which Mission to Lepers worked. And that is something very unusual, because they didn't know English, and this was something translated. It's translated, transfigured, something concocted, made up, perhaps. And large donation came from the government, because they were very, not, there was no kind of compulsory segregation. All segregation was voluntary in these leper asylums. There was no compulsory segregation like the other leper colonies or archipelagos. Okay, Cape Colony or Philippines. There was no compulsory segregation was in India. Only the voluntary segregation. But whenever they found, means the police, the authority, they found the lepers loitering around, they started to confiscate them, started to collect them and to put them into the leper asylums. But there were many instances of escapes. Many instances of escapes, and the leper asylum, the way in which they were governed by the missionaries, is very stringent, because the policy of segregation of sexes were strictly maintained. And a government asylum, there were very nominal or a very small number of government asylum existing in India. Only the missionary asylums were existing. So the government followed the way the missionaries worked, the way missionary governed those asylums. The segregation policy, the segregation of sexes, the married couples, they were separated. So all the time there was chances of escapes. Now, I just want to share one interesting story. There was a leper asylum at Naini near Allahabad. The superintendent of Naini Asylum was Sam Higginbottom. There was also an institute. There is also institution, agricultural university, that's named after Sam Higginbottom Agricultural University. I don't know whether it. I think it exists. So that Sam Higginbottom, he was very very cordial and very flexible about this. And he encouraged a married couple to stay their asylum. And there was, in that asylum, the segregation of sexes was not strictly maintained. So all these escapees from Bihar, from Uttar Pradesh, and from other parts, central province, they always wanted to go to Naini at the Sam Higginbottom's place, asylum. Now, in 1908, there was a conference, I think it's in Purulia. At that Purulia conference, leprosy conference, all superintendents, they objected and they complained against Sam Higginbottom that you are actually giving them shelter and you didn't follow the missionary rules. The mission to lepers clearly stated that the segregation of sexes should be maintained, followed, but you didn't follow this, and that's why you are encouraging them to escape from the respective asylums. And they appealed the government and mission to lepers to expel Sam Higginbottom from the institution, from any asylum. I have no idea that what happened after that, but it continued. Okay, it continued. And also, in one chapter, I have explored the way in which this leprosy research started in India. Okay, I told you that there was no cure in 19th century. Now, prior to the establishment or foundation of the Calcutta School of Tropical Medicine, there was hardly any uniformity in medical research on leprosy. Number of instances I have referred to, number of claims, clandestine claims, they didn't want to share the composition of drugs, but they claim that I have the cure of this disease. So, and some American, I just remember one American doctor, he claimed that, yes, I have the cure, but I didn't want to disclose that unless and until I have the permission to diagnose or to treat the leprosy sufferers. I didn't want to disclose that. So government rejected his proposal. So these sort of references I have got, but there was no uniformity. Only what I have found that Leonard Rogers and some other associates, they started experimenting on cholmogra oil, administering cholmogra oil since 1916. And they didn't get quite success in that. But after, and that's why he wanted a kind of tropical disease research institute. Now, I also have explored the way in which this tropical disease research came into being, how this tropical disease research formed in India, what was the pretext, and how the colonial masters and the public health expertise, they wanted the medical institute only for the tropical disease research should be established in the tropical areas, because the materials, the specimens, and all other primary data would be easily available rather than establishing tropical disease research institute in Europe. Though Liverpool and London School of Tropical Medicine came into being in 1898, 1899. Now, the point is that having that structure in mind, Leonard Rogers wanted All India Tropical Disease Research Institute. And that's why he explained that why we should need Calcutta School of Tropical Medicine. And initially, his proposal was rejected, but then in 1916 and 17, the government of India agreed, and in 1920, it started its journey. Though the foundation happened in 1914, 6 years, you know, there were governmental paraphernalia, and it became standstill. But from 1920, it started operating. Okay. Now, the first leprosy research department established, perhaps, or in the world, was the Calcutta School of Tropical Medicine. Calcutta School of Tropical Medicine Leprosy Department, full-time leprosy research department. That is the only leprosy research department at that time in the world. And the first man who took this department was Ernest Moore. He was proposed by Leonard Rogers. Leonard Rogers, in 1920, he left India. And before that, he called Ernest Moore to take over the charge of Calcutta School, the leprosy department, Calcutta School of Tropical Medicine. Number of pioneering and valuable research happened since 1920s to 1950s. We have number of leprologists during this time. Ernest Moore, R.G. Cochrane, John Lowe, Dr. Dharmendra. These people were unsung heroes. And we only know about Ronald Ross and other people, but these people were hardly named in every event. Nowadays, I don't know what is the condition of Calcutta School of Tropical Medicine. In 2018-19, the leprosy department was totally stopped working, merged into the other tropical diseases department. I don't know whether it is now still open or, but still, the Calcutta School of Tropical Medicine showed the way. Pioneering research happened, and sulfon drugs, even the MDT, the multi-drug therapy, that the drugs that are actually used, these drugs are the outcome of the research that happened from 1920s to 1950s. And Dr. Dharmendra said that not only this curative drug, only the medium, that won't cure the disease. You have to be very vigilant. There is a method called PTS, Prevention Treatment Survey. This Prevention Treatment Survey first raised by Ernest Moore in the Calcutta School of Tropical Medicine. And this PTS method still we are following in a different way, in a different form. But this PTS method, this Prevention Treatment Survey, this is something that we have to continuously monitor the leprosy cases. But I don't know whether we have succeeded or not, but still we are struggling. Still we are struggling because of our mentality. And that is something that I have referred to in my 4th chapter, that how the Bhadraloks, Bengali Bhadraloks, they had perceived and still are perceiving leprosy sufferers, the disease, and how the idea of degeneration enmeshed or entangled with these approaches. I have gone through several vernacular sources, vernacular newspapers, journals, public health periodicals. Even some of the articles, they were translated from English. Okay. But there are other articles published in Ayurveda journals. They were talking about indigenous treatments, indigenous herbs for the treatment of leprosy. So not only the treatment, but also the way in which Bhadraloks, the dynamism of their approach. On the one hand, they were very lenient. They were very sympathetic towards leprosy sufferers. On the other hand, they were very angry about they were very angry to the colonial government, why they allowed those leprosy sufferers to stroll, to loiter around, why they were not prevented, why they were not confined. There should be a stringent confinement policy. And they expressed it in various articles, editorials of the contemporary newspapers, Hitobadi, Shomprakash, lots of medical journals, even the one paper that published by Manbhum that time, I think Purulia, that published from Purulia, it's called Mukti. Now Purulia, Birbhum, this region was leprosy infested. These regions were leprosy infested. Even if you see the reports, census reports and public health reports, Purulia, Birbhum, mainly the Bardhaman presidency and Bardhaman province and Purulia, these regions, the leprosy sufferers existed a large number. And the Purulia leper asylum was there, Raniganj leper asylum was there, Asansol leper asylum was there. So all these leper asylums existed there. So that were those leprosy sufferers were very problematic. They created nuisance at the public places. They were loitering. They were selling fruits, vegetables, and that was very annoying for the Bhadraloks. So they kept writing letter to the editor of Mukti that why don't the government take any steps? Why they are silent about these people? Why they were not confined? As the Leper Acts of 1898 says that the leprosy sufferers, indigent leprosy sufferers, leper beggars, they should be confined. Why they were not confined in Purulia? So on the one hand, they were very sympathetic. Even when there was a question of fundraising, I think the Calcutta Leper Asylum, there was a fund crisis in running Calcutta Leper Asylum in 1870s, 1880s. Justice of Peace and the Charitable Trust, they were very, you know, in a one way or the other, they tried to push this responsibility to others' shoulder. So they said that no, we are not going to take this responsibility any longer. We are approaching the government. The government will take over the charge. Now, at that time, though, when Calcutta Leper Asylum was going through a financial crisis, there was a question of fundraising. Yes, the Bhadraloks, they were very eager and they were very happy to shift this Calcutta Leper Asylum from Amherst Street to Gobra, nowadays Park Circus. It existed in Amherst Street, and in 1870s, 1880s onwards, the local Bhadraloks, they objected and appealed the government to shift this establishment to elsewhere at the fringes of Calcutta, because now the population is growing and this leprosy, in the midst of in Calcutta, in the midst of so crowded place, it's better to shift this leprosy institution elsewhere, because existing a leprosy institution in Amherst Street would be dangerous for the others, for the healthy people. So kind of binary already created by the Bhadraloks, by the state, healthy and unhealthy. The unhealthy should be confined to whether it is hospital. In hospital, it is totally treatable. The people will. It's not that the leprosy sufferers, they were not admitted to hospitals. They were admitted to hospitals, but mostly they were in outdoor hospitals, not the indoor hospitals. They were not encouraged to stay in the hospitals. They were encouraged to stay in the leprosy asylums. So when there was a question of fundraising, I don't remember, but an interesting suggestion came from Bhadraloks that why don't we put a particular leper in a street, in a prominent area of a particular junction, and give him a placard that we need money for the leper asylums. So they will all offer money. The passers-by, they will offer money. So this is an interesting question, that you are using a leprosy sufferer for fundraising, and you are still saying that why they're loitering, why they were not confined. So you're using them and also you are dejecting them. That is very interesting area, that interesting angle that I have come across.
Dr. Dash, sorry, I'm interjecting a little bit. I'm just aware of time, and there might be some questions. So, do you want to conclude in maybe the next 1 or 2 minutes so that
I'm just
can?
concluding
Sure.
because it's very difficult, to sum up the entire thing into 45 minutes. But really, what I have written in my conclusion is that we are still struggling with this mentality, because the mentality that prevailed, that actually created that leprosy is contagious disease. Yes, it is contagious disease, but it's not as contagious as smallpox. It is treatable. And the issue of confinement, so much associated with leprosy, I don't think that other diseases, they have such kind of association. Bodily manifestation. Even you have the bodily manifestation in STD as well, sexually transmitted disease. But and it's also kind of the leprosy and sexually transmitted disease, and they were going hand in hand, because in still 1950s, the people who are researching on STD, they are also treating leprosy, because the diagnosis more or less was same. Now it's totally different branch, but still those who are treating STD, they're also well aware of leprosy treatment. But the thing is, the bodily manifestation, this association, confinement, this fear of confinement, fear of seclusion, segregation, that actually leads to concealment of disease. And here we, not only the medical workers or the doctors or the physicians, but also we have failed to popularize this idea, this survey, this prevention, treatment, and survey. We popularize this PTS, and we fail to aware them that it's totally treatable, it's curable. There is no concept of curse. It's not curse that you are actually bearing on your mind or in your body. It's a disease, and it's curable, and it can be cured. If you take MDT, if you follow the procedure, then it will be cured. But nowadays, which is alarming, and I just want to say a few words, that the government of India and also the local governments, they are very lackadaisical in this sense. The fund that we have now is getting reduced day by day. Budget, if you see 2024 budget, so many cut fund. There is a separate fund on NLDP, National Leprosy NLEP, National Leprosy Eradication Program. Now all the contagious diseases, they were clubbed into one section. That is the small portion that NLEP now get, only a small portion of the GDP. That is very problematic, number one. Number two is that even when, even in the physician, the circle, within the physician circle, it is regarded, the leprosy officer, this post is regarded as punishment post. So nobody wants to treat the leprosy patients in the rural areas, interior areas, because it is considered as punishment post. So basically, there is a kind of problem in our mentality, our approach, not only in our society. And I have found a very alarming figure in South Chobbish Pargona. In South Chobbish Pargona, in West Bengal, South Chobbish Pargona, this disease is increasing. And there is also an increase in concealment of the disease. They actually treat this disease as a mere kind of source. This is various sorts of source, and they can be treated. But these sources are actually the signs, the early signs of leprosy. And this concealment is very dangerous. Now, my earnest request to the audience and those who are listening to me, and also through this event, I just want to say that this is something that we need to share, that leprosy is a treatable disease and leprosy is a contagious disease. We have to tell this. Leprosy is a contagious disease, but it's not as contagious as other epidemic diseases. So don't be scared. Don't get scared. It's treatable completely. And if there is any kind of patches that you are aware of, that are manifesting, please go to the hospital, local centers. And there's the conditions of the local public health centers, regional public health centers are horrible, So the situation is very gloom, very, very dark. But still, we hope for the best. And I say that, okay, you should think for the best. Okay. So this is it. This is largely my work. And I don't know if I do justice to my work or not. The audience will tell me.
Thank you. Thank you, Dr. Dash. It was a very wide-ranging talk on different aspects of how leprosy was handled by the colonial state machinery and all the social complications it led to, the segregation practices, as you were discussing. And I also like that point towards the end, especially about the question of the Bhadralok, which went back to your initial comments on the dynamic of objectification, right? That you're using a leprosy sufferer to sort of raise awareness and also fundraise, right? So that idea of objectification, but then how it created a certain binary confinement, and this idea of the healthy and the unhealthy body. What is it that is creating a certain regime of, let's say, visual displeasure? Because in medical humanities we often talk about this idea of as you said, the healthy and the unhealthy body being a binary, and a certain visual displeasure produced by the unhealthy body sometimes stigmatizes a disease. Absolutely. Much more than its actual technical details would stigmatize it. As you were saying, it's not as contagious as it is made out to be, perhaps, right? And you ended on a note of awareness. I won't take more time. I'm sure there are students, audience members. Professor Sengupta is here, Madhumita Di. Anyone, if you have questions, comments, feel free to go ahead. You could unmute yourself and speak. I think that right should be there with everyone. Right, Aniket? I think everyone can unmute and speak, right? So it should be fine. Yeah. Yeah. Madhumita Di, yeah. We can't hear you though.
No?
Yes.
Can you hear me? Yeah.
Yes.
So thank you all. An interesting talk and about objectification, leprosy, colonial state, and the confinement. I think I'll take my time and let the students ask first, perhaps, and then maybe I can come back with the questions.
Sure, sure. Anyone else, please go ahead. You can unmute yourself and speak. In case you want to put your questions in the chat box, that's also fine. We can relay that to Dr. Das. Questions, comments, anything that you would want to perhaps, ask him as someone who has worked in this field, if, from a practical point of view, because he did talk quite a bit about research experience initially. And if you want to say anything about. Seems like everyone is quiet.
I think in that case, I'll begin.
Okay, sure.
Apalak, I was just listening to you and wondering, it could be there in your book. I haven't read the book, but I was wondering if you noticed any difference in the way the state, the public health institutions were working and the way the missionaries were, sort of treating their own patients. Because in many cases, at least with my experience of working in the Northeast, I found that the missionaries had a different approach towards the patients. I'm not necessarily talking about contagious diseases, but other kinds of diseases, which was why the missionaries were considered as far more, missionary hospitals and establishments were considered as far better than the government hospitals. And did you encounter any such difference with regard to leprosy?
Yes, to some extent, there was a difference between, in terms of running an institution. Yes, of course, there was a difference between government asylum and missionary asylum. But the thing is, it's an interesting liaison that existed between the government and missionary. Now, the government was anxious and was not ready to take the entire responsibility of the leper asylum. So they shifted their responsibility to the missionaries. And largely, there were a handful number of leper asylums existing in India in 19th and 20th century. Most of the asylums were controlled, run by missionaries, mainly the Mission to Lepers, London Missionary Society, parts of American Baptist Missionary. They played an important role or played a part of this. But the thing is, the way in which missionaries worked, that actually intrigued the government. And largely the government asylum, British India and British government, they followed the same policy that were followed in the leper asylums and missionary leper asylums. So in that way, if you go through the directives, if you go through the Albert Victor leper asylums, proceedings, meetings, everything, and if you compare that to the annual report of the Mission to Lepers, then you will hardly find any kind of difference. And it happened mainly after 1901, 1908. Means when the Lepers Act of 1898 was fully implemented, entirely implemented all over India. And when it was the confinement policy was acknowledged as the only medium to prevent leprosy, on very particular point of time, there was a shift of approach, colonial approach. And prior to 1898, the colonial state took a kind of, what should I say? It's a kind of, they were not concerned about the procedure, how to control those leprosy sufferers. Once they got the, a kind of instructions from Mission to Lepers, these should be the medium, these should be the procedure. This is how, these are the ways, the way in which they were controlled. Now, once they got the procedure, they followed that procedure in the government asylum as well. So now the one interesting difference is that the government asylum was very secular. On the other hand, the missionary asylum, in missionary leper asylum, there was a question of proselytization. Though the superintendents of missionary asylums, they claimed that this proselytization was voluntary, and if anybody rejected, or if anybody, it's on the personal choice whether they would embrace Christianity or not. It's totally for their personal choice. But having said that, the missionaries, the way they approach them, the way they entangle the concept of cure with the care, there was no way except to embrace Christianity. Because you are taking shelter in a missionary asylum, there was a church. Every Sunday there was sermon happening. So you couldn't escape all those things, na? There are no only ways. So the proselytization was a natural process. It turned into a natural process. The dejected population, the leprosy sufferers, they had no option in the missionary asylums except embracing Christianity. Okay, so
Okay,
and the Christianity was the medium. How many leprosy sufferers were baptized? they had to show the report. They had to show the figures in their annual reports. And in that way, this was not encouraged in the government asylum. The government asylum was much more secular. There was no church. There was, interestingly, there was a seclusion as well. Even it reminds me of one instance, Albert Victor Leper Asylum or Albert Victor Leper Hospital since 1935. This hospital was largely, run by private subscription and the government subscription, right? Now jointly. And some amounts came from mission to lepers. Now the thing is, one Marwari, he donated a lump sum for erecting a ward and named after his father or whatever. And he gave conditions that you have to, this is only for the Hindu leper beggars or the Hindu leprosy sufferers. This word strictly used for Hindu leprosy sufferers. The Hindu cook, Brahmin cook should be employed. Not only other cooks, no, there would be no non-vegetarian food. Non-vegetarian food would be allowed in that ward. Okay, so in this way, a kind of not only the segregation of sexes, but also the religion came into being, and this question of the worship came into being. But being a secular institution, how could you say that the only Brahmin cook will be employed? Because the most of the people, they were Hindu leprosy sufferers. So that is the thing.
Just to interject this, another thing that I wanted to ask, and you brought it up, and that was the question of statistics. You said that the statistics about proselytization had to be mentioned in the annual reports of the missionaries. What do these statistics say? I mean, what were the percentage of confined patients who were baptized, who became Christians, and also what was the time? What is this statistics about patients who were cured finally, who came out of the asylum eventually and could resume a normal life? Encountered these statistics.
Okay, the thing is, since 1880s onwards, I mean, the Purulia Leper Asylum established in 1884 or 1888. Now, since the establishment of Purulia Leper Asylum, the number of the figures escalated in a proportionately, okay, exponentially. The number of proselytization happened exponentially. In 1910, 1920, if you go through the annual reports and annual reports of mission to lepers, then you will find that the number of proselytization increased exponentially. But the question of cure that you have raised this point, the question of cure was very fluctuating. As there was no cure at that time, prior to 1920s, as there was no cure, and there was question of re-entering, because those who got cured, they freed, and then again they entered, because again the bodily manifestation came out, because that cure was not successful. So they again came to leper asylum, or they escaped from the asylum, then again caught by the police officers, the administration, then they were put to leper asylums again. So the number got fluctuated every year, every time. But the proselytization increased. Even the children, men and women, these three categories, they were proselytized. They were proselytized. This is something that very interestingly I've come across, that when there was, they say the superintendents of the leper asylums, they explained that this time we have cured such patients, and on the same time, or at the same time, they're saying that in this year we have proselytized this number of people. In Purulia Asylum, in other missionary asylums, okay, number of missionary asylums, they showed that, and there was a kind of competition. In Purulia Asylum, they said that we have increased the proselytization, in that degree. And other asylums said that no, this time we have increased. It's a kind of we have proselytized so many people, the leprosy sufferers. So there was a kind of competition. I thought that it's an interesting way to cultivate those reports. And the number of cures that you are talking about, it's very encouraging after 1920s, when the Calcutta School of Tropical Medicine, they finally took over this responsibility. Okay, we are going to find out the cure. And kind of uniformity came into being, a kind of uniformity they are looking for. And from that point of time, since 1925, 1926, there a kind of steady decrease we are witnessing. The figures that escalating, from 1900s. And if you see the census, it's very interesting to see census, because the 4 categories they were mentioned in the census, the one is blind, another one is deaf and mute, another one is insane or lunatics, and the last one was leprosy sufferers. So if you go through the census from 1881, the first decennial census happened in 1881 till 1931, then you will find that every time the census officer, superintendent, he claimed that this time we have followed more scientific determinants. We followed scientific. We actually wanted to show scientifically, and this time this kind of figure is actually the accurate figure we are showing. So that's why in 1921 they claim that this time this is the exact figure that we are seeing. In 1931 say no, the 1921 the procedure followed in 1921 was not accurate. This time it was accurate.
Dr. Das, sorry, there's a longish question in the chat box
Okay.
from one of our doctoral students, Manush. Is, I mean, let me relay the question to you, but you could also have a look if you want. You talked about objectification of leprosy bodies. Objectification was a premise on which colonial epistemology was built throughout the world, not just in India. It reminds me of lock hospitals, where STI infected bodies were segregated in different wards from the rest of the population. What's interesting is that there used to be 2 types of lock hospitals, one meant for the infected woman and the other meant for the infected soldiers. It was the former whose bodies were objectified. I was wondering whether or not this objectification was uniform in the grand ambit of colonial medical policies throughout India. Was this rhetoric of objectification different for different bodies? Yeah, that's Manush's question. So, I mean, I guess it's also a question about maybe gender differentiation, whether there was a certain gender differentiation in the practices of objectification or discrimination that happened.
Sorry, I couldn't get you the last because the connection.
Right. No, sorry. It's no. I think the question is about. I mean, among other things, he's asking whether there was gender discrimination, and maybe so. Was it? Of course, the diseased bodies were discriminated, but was it one uniform kind of discrimination that the diseased bodies faced, every leprosy patient faced, or was it more like, it was divided across and in different ways by gender, class, caste? You did bring in the Bhadralok question, right? So sorry, I'm just adding to Manush's question there. Yeah.
No, but this question is very interesting, and this is something that Jane asked me to explore. That while you are pursuing research on leprosy in colonial Bengal, take this 2 or 3 themes into consideration. That is the gender aspect. But I didn't look at that aspect in detail in my book, because it's already so lengthy and I hardly got time to look into that matter. But yes, I have written I have written one article on gender leper woman, female lepers. And it actually is very interesting that female lepers, they were segregated and they were easily proselytized. They were so soft, because they were depicted in that way. And different types of names were given to those female lepers, young female lepers, the elder people. They were named by the superintendents in different way. I have found one mention of marigold. Okay, so this actually marigold flower, but it's actually a name of a girl. It's not mentioned, but it said I have referred, I have given marigold, I have given the name, the marigold, to that lady. So they were segregated when there was a question of segregation of sexes. I have mentioned in my talk. Obviously, they were easy targets in missionary asylums. But I didn't take that into consideration much, because this is something that the other researcher can pursue, that the gender question. It's very interesting, and hardly I have gone through. Okay.
Okay, I think we have run out of time, but if there's one last question, we could take that from the floor.
Is somebody trying to say something, or
I think that might be a background noise, or I'm not sure if someone has unmuted. If there is a question, please feel free to ask. We can only take one last question now. Is there a question from anyone in the audience? I think that's just an unmuted microphone. Okay. If not, maybe this is a good point to thank Dr. Das for this very interesting and, as I said, very diverse talk that began with his research experience and ended with the book. Thank you so much for making the time to contribute to our seminar series. And I hope to see you, more informally in the real world, where I would call you Apalak rather than Dr. Das, maybe.
Okay. No, absolutely. I'm very delighted. I'm flattered.
Okay.